Welcome. My name is Rachel Bella Kramer, and I am the Opioid Settlement Coordinator with the Chester County Department of Drug and Alcohol Services. I'd like to thank the Chester County Medical Society for providing this virtual venue for us to provide more information relating to substance use disorder. Today's lecture is the third in a series of 4 lectures, and they are held every other Thursday evening, the next one being June 20th. Before I introduce tonight's speaker, I would like to let you know that we firmly believe that recovery is possible and it is happening every day throughout our communities. I would also like to say that in Chester County, you don't have to take out a second mortgage to obtain substance use disorder rehabilitation services, as it is available to the uninsured and underinsured at no cost to the individual or their family. I encourage you to sign up for our newsletter, and I will post links to our website and other resources that are available in the chat. If you have any questions during the lecture, please place them in the chat, and they will be answered during our Q&A session at the end of tonight's lecture. With that, I'd like to provide a brief background of tonight's speaker, Dr. Christopher Davis. Dr. Davis received his undergraduate degree in electrical engineering from the Pennsylvania State University and his Doctor of Osteopathic Medicine from Southeastern College of Osteopathic Medicine. His dual residency in internal medicine and pediatrics was completed at the Geisinger Medical Center in Danville, Pennsylvania in 1994, and he is board certified in internal medicine. Dr. Davis has developed and taught both an undergraduate and graduate level course on addiction and addiction counseling at Millersville University. Having started his practice in primary care, Dr. Davis branched out into treatment of substance use disorder. He has worked both as a clinician and a medical director in a variety of settings to include an inpatient detoxification program and residential methadone and outpatient Suboxone clinics. Currently working in his private substance use disorder practice, he is a diplomate of the following: the American Board of Preventive Medicine, the American Board of Internal Medicine, and the American Board of Addiction Medicine. Please join me in welcoming Dr. Davis. Dr. Davis, I'll turn it over to you.
Thank you, Rachel. Thank you very much. Thank you for joining me for my third and final talk. First one was on the disease model of addiction and medication-assisted treatment for opiate use disorder. So we're going to wrap it up today with medication-assisted treatment for alcohol use disorder. If I can get my slides to advance. Okay, there we go. I think that's right. Yes. So excessive alcohol use was responsible for about 178,000 deaths in the United States each year during 2020 and 2021. And this was a 29% increase from the years 2016 and 2017, when there was an estimated 138,000 alcohol-related deaths. When you look at that 178,000 deaths, 2/3 of those, so it's about 117,000, were due to chronic conditions that develop from long-term alcohol use. So like most of them being alcoholic liver disease, but also congestive heart failure, various cancers related to alcohol use. So that's about 2/3 of the death. And then 1/3 of those deaths, which would be about 61,000, happened from drinking too much on one occasion, such as being intoxicated, involved in a motor vehicle accident, or poisoning as a result of alcohol use and other substances, and suicides. The majority of suicides will involve alcohol use at the time of the suicide. So when you look at that number, 178,000 alcohol-related deaths in 2021, compare that to the number of drug overdoses in 2021, which was about 107,000. So there were actually more alcohol-related deaths than there were drug overdose deaths. But we seem to talk a lot more about opioid overdose deaths or drug overdose deaths. And we forget that alcohol is a huge problem in this country. When a 25-year-old kid dies of a fentanyl overdose, we hear about it. But when a 55 or 60-year-old person dies of chronic complications from alcoholism, it just doesn't get talked about much. roughly 29.5 million people in the United States have a have an alcohol use disorder, and heavy drinking costs this country more than $249 million annually. Now, this graph looks at alcohol-related deaths per 100,000. So if you can see my cursor moving there. So we have males, number of deaths slightly increasing, and then 2019 it takes off. We have females, same thing, slightly increasing over the years, takes off, and then the middle is just the average of the two. So 2019 was a turning point, although it had been rising before then. After an annual increase of 7% or less between 2000 and 2018, the rate of alcohol-related deaths increased 26% from 2019 and 2020 to 2020. That's what that graph shows. So even before the COVID-19 pandemic, rates of excessive alcohol use were high and getting higher. It appears, though, that the stress and social isolation from the pandemic has worsened harmful drinking significantly. Sales of alcohol rose during the pandemic. Alcohol-related hospitalizations and emergency room visits and alcohol-related deaths all rose during the pandemic. And this also shows kind of the same thing I'm talking about. This is alcohol-related deaths per month in 2019. All of a sudden, 2020 starts to climb significantly and has stayed high. Alcohol was the most common drug in drug-related emergency department visits, which when I was first researching this actually surprised me. I thought there were probably more overdoses, opiate overdoses in the ER, but no, it is alcohol. So let's talk specifically about medication-assisted treatment for alcohol use disorder. So over here is Vivitrol, which is an extended-release form of naltrexone. We'll talk about Disulfiram or anti-abuse, a form of aversion therapy, Acamprosate or Camprol, oral naltrexone, and we'll briefly talk about some off-label medications towards the end. In 2019, only 7.3% of Americans with an alcohol use disorder received any kind of treatment, counseling or inpatient treatment. I mean, that's a small number. We're doing a terrible job in treating alcohol use disorder. Patients are not getting into treatment. And only 1.6% were prescribed any medication for an alcohol use disorder. That's horrible. Less than 2% of patients who might benefit from some form of medication-assisted treatment ever got prescribed anything. We do a much better job using medication-assisted treatment for opioid use disorder than we do for alcohol use disorder. So these are the 4 FDA-approved medications for alcohol use disorder. So Disulfiram, anti-abuse, which is an oral medication, form of aversion therapy, oral naltrexone, sustained-release injectable naltrexone, known as Vivitrol, and Acamprosate, also an oral medication. So if there is such a thing, what would be the ideal medication to treat an alcohol use disorder? Well, it would be some kind of medication that would reduce cravings or the urge to drink. It would reduce the reward or the euphoria from alcohol if the person drank. It would be something that's non-addicting, meaning dependency doesn't develop. It would have minimal or no side effects. And most importantly, it reduces or stops drinking. And there's many ways of measuring that. Days of drinking, amount of drinking, number of relapses. Some of the studies we'll go through have various endpoints that they're looking at. Days of heavy drinking, days of any drinking, complete abstinence rates, and so on. So it's sometimes hard to jump from study to study because they look at different endpoints in alcohol use. So for those who are a primary care physician, what is the role of a primary care physician in treating somebody with an alcohol use disorder? Well, probably initially screening patients for a possible alcohol use disorder. Do they have alcohol dependency, abuse, the old DSM-4 criteria, or some type of alcohol use disorder? And there are various screening tools. I'm not going to get into them, the audit, the CAGE, and so on. The physician needs to be aware of medication options, and hopefully we'll learn something from today's talk in regards to that. Assist the patient in the referral process for specialty care. Maybe the patient needs to get into a residential detox, or an inpatient rehab, or outpatient counseling, and initiation of pharmacotherapy and monitoring the patient for compliance and side effects. So I'm going to bounce back the old DSM-4 criteria, abuse and dependency. So one way to look at alcohol abuse is the intentional misuse of alcohol to the point where it's causing that individual problems in their life. So it could be legal problems, or health problems, or relationship, employment problems, education problems. And the etiology of abuse is the environment and behaviors. So a real good example of that would be college fraternity students. So 85% of male college fraternity students binge drink and misuse alcohol. 85%. Now, if you take that group and follow them over the years, what you'll find is the vast majority of them will finish school, get married, have children, get employment, and their drinking will become normal or social or non-problematic. The majority of them don't proceed on to have an alcohol use disorder. About 10% of them, however, when you examine them years later, you'll find they're drinking the same way they drank when they were in college. Those were the ones that had the disease of alcoholism. The vast majority of them were alcohol abuse because of the environment that they were in. And if you think of dependency, or the disease of alcoholism, alcohol dependency is a neurobiologic disease which results in the compulsive use of alcohol, despite it causing the individual significant problems. And there's loss of control, or loss of ability to moderate consumption. That's a big component of this disease, loss of control. Tolerance and or withdrawal may develop, and there are genetic factors that predispose the individual to having the disease of alcohol dependency. However, the environment and social factors and psychological factors do contribute to the onset of the disease, how early it presents itself, and the progression of the disease, but they're not the cause of the disease. And we talked a lot about this in my first talk on the disease model. So think of the disease model as a neurobiologic disease where there's an inherited and or acquired neurotransmitter receptor dysregulation or imbalance that results in that compulsive use of alcohol, despite it adversely affecting the individual's life. Family history or genetics is the biggest risk factor for this disease. However, the environment, social, psychological factors also play a role, as I just mentioned, in the progression of the disease. So if as a physician you accept the disease model of alcoholism, then medication management makes good sense. I mean, there are various brain diseases that we use medications for. Parkinson's disease, where there's an imbalance in dopamine release and dopamine receptors in the substantia nigra. We use medications for Parkinson's disease. Schizophrenia, also due to dopamine imbalance. Epilepsy, seizure disorders, Alzheimer's disease. These are all brain diseases that we use medications to treat. Leading up to the first medication we're going to talk about, which is antabuse, disulfiram, I want to kind of go back to an older model of alcohol dependency, the conditioned model. So with this model, alcoholism is felt to be a bad habit. The addictive use of alcohol is a learned behavior that can be unlearned. So think about Pavlov's dogs. They would ring a bell and they would feed the dog, and then ring the bell and feed the dog. And with time, the dog would associate the bell ringing to food coming. So then you could get to the point where you ring the bell and the dogs would salivate. So it was a learned behavior, but it also could be unlearned. So you could ring the bell then and not feed the dog at a different time. And if you continued that, that behavior would be unlearned so that when you rang the bell, the dog didn't salivate anymore. So if this is a learned behavior that could be unlearned, then aversion therapy might be an effective treatment for alcohol dependency. Alcohol dependent individuals. This is interesting. So this is a silly study that was done many years ago, and it really was done. And what they did was they wanted to prove that a person with alcohol dependency could unlearn their drinking behavior. So what they did was they took a lot of alcohol dependent individuals and they entered them in this study and told them that they could drink whatever they wanted as much as they wanted. So they would go to this place and it was a bar, they could get whatever they wanted. However, there was one caveat. There were electrodes placed in the glass. And when the person would drink, they would periodically and unpredictably be shocked. So they would go, I have my glass here, they'd have a drink and have a couple more drinks. At some point, they would get a shock. So that was aversion therapy. And so they wanted to see what that would do to their drinking behaviors. And what did they find? Well, they found that there was a marked decrease in alcohol consumption from all glasses that had electrodes in them. But the bars down the street didn't have electrodes in them, so the drinking continued. So again, it seems like a silly study. It actually was done, but it really showed that aversion therapy didn't make a difference in the long run in terms of their drinking outcome. So aversion therapy works great in training dogs not to urinate on the carpet. Urinate on the carpet, you spank them with a newspaper, but it's not beneficial in treating addiction. Think about this. The alcohol dependent individual has exposed themselves to aversion therapy for years before they ever come to treatment. They've already had job losses, marital problems, arrests, mental anguish, physical, psychological deterioration, yet they continue to drink. So that sort of leads us up to our first medication, Disulfiram or antabuse. So this was the first medication that got FDA approval for alcohol dependency. It got approved in 1949, and no other medication got approved for treating alcohol dependency until oral naltrexone in 1995. This is considered deterrent or aversion therapy, and if an individual drinks while on this medication, they become violently ill. It's called the antabuse reaction. How does it work? Well, finding my cursor here, all forms of alcohol that we consume are ethyl alcohol. And when we drink, ethyl alcohol gets into our bloodstream, goes to our liver, and an enzyme in our liver called alcohol dehydrogenase breaks it down to acetaldehyde. Acetaldehyde is very toxic, probably plays a big role in the hangover. It's chemically similar to formaldehyde. So the body doesn't want to keep this around very long because it's so toxic. So another enzyme in the liver called acetaldehyde dehydrogenase then breaks that down further to acetic acid or vinegar, and then further into water and carbon dioxide. What antabuse does is it blocks this enzyme, acetaldehyde dehydrogenase, so that when the patient drinks ethyl alcohol, acetaldehyde levels rise rapidly and remain high, and then it causes that antabuse reaction. So basically, it punishes the person for having a relapse. Now, something interesting is within the Asian population, a large percentage of them have diminished acetaldehyde dehydrogenase activity. And when they drink, they will get an antabuse-like reaction, usually not as severe, but flushing is very common. And also the incidence of alcohol dependency within the Asian population is much less than in other populations. And it may be partly because of this defect, or I don't even want to say defect, but because of the diminished activity acetaldehyde dehydrogenase has, so it becomes protective from them going on and developing alcohol dependency. So what is the anti-abuse reaction? Skin flushing, nausea, vomiting, diarrhea, chest pressure, shortness of breath. They all described as throbbing headache, and these symptoms may last for 30 minutes up to several hours. And as I mentioned before, it punishes the alcohol-dependent person for having a relapse. The individual has to be alcohol-free for at least 12 hours before starting anti-abuse. Actually, they have to have a blood alcohol concentration of less or of 0 to start the medication. So however many hours that is needed to get a 0.0, that's the point when they can start the medication and not get ill. So it's taken orally, it's a pill once a day. The initiation phase, you give 500 milligrams a day for 1 to 2 weeks. I've actually never done that. I just go right to the maintenance phase of a 250 milligram pill a day and just keep them on that dose. And I don't use this medication very often, and you'll see why as we kind of review some of the studies. If the medication is discontinued, consumption of alcohol for up to 3 days later may result in the anti-abuse reaction. So probably the largest study looking at anti-abuse in the alcohol-dependent population was the Veterans Administrative Cooperative Study done way back in 1986. So in this study, they took 605 men, and they were randomly assigned to get disulfiram, 250 milligrams a day, or placebo. All participants received traditional drug and alcohol counseling. Patients were maintained on the medication and continued in counseling, and they were followed for 12 months. So what did they find? So the first endpoint they looked at was complete abstinence rates. So, what percentage of patients had no alcohol use during the entire 12 months, whether they were on placebo or disulfiram. So when you look at this graph, you see that the placebo group had less than 20% had complete abstinence. Disulfiram, less than 20% had complete abstinence. It actually looks like the placebo group had better complete abstinence rates than the disulfiram group, but there was no statistical difference in these two. So we would consider them equivalent. So we can say disulfiram versus placebo, complete abstinence rates were no different, and they were pretty terrible too. So compliance with taking the medication was low. So even though the participants were unaware whether they were taking the disulfiram or the placebo, compliance was terrible. Only about 20% of participants remained compliant on the medication, whichever they got, placebo or disulfiram. Only 20% remained compliant with the medication for the 12 months of the study. So they started to ask the question, well, what if we examine those who were compliant with taking whatever pill they got? How did they make out? Did they do better if they were compliant? So this graph kind of looks at that. So first, we'll start with the 80% that were non-compliant with taking whether it was placebo or disulfiram. So that's the purple. So you can see that if they were non-compliant with taking it, and this is complete absence rates, the placebo group had horrible complete absence rates. The disulfiram had horrible complete absence rates. Not surprising. If you're not compliant with the medication, you're probably not going to have a good outcome. So then they said, well, let's look at the 20% that actually did take the medication. How did they make out? So this would be the compliant group, the 20%, and that's yellow. So if they were compliant with taking placebo, what you can see is about 40% had continuous abstinence. If they were compliant and taking disulfiram, a little less than 40%. Again, it almost looks like the placebo group did better than the non-placebo group. But again, there was no statistical significant difference between these two. So essentially equivalent. So when we look at this, we can say, well, if you're compliant with taking a medication, whether it be placebo or disulfiram, you seem to do better with complete absence rates than if you're not compliant with taking a medication. And that kind of intuitively would make sense. And then the other thing they looked at in this study is number of drinking days. So instead of complete absence rates, number of drinking days. So what you can see in the placebo group, about 80 some days of drinking. In the disulfiram group, about 50 some days of drinking. This was statistically significant, this difference. So we didn't see much effect in complete absence rates, but it did appear that the number of drinking days was better for the disulfiram group. So what can we conclude from this VA study? So compliance rates for taking medications were terrible, 20%. Those who were compliant with taking the medication did better, regardless if they were on placebo or disulfiram, than those who were not compliant. So the compliance of taking the medication may actually just be a measure of motivation. And the patient who's more motivated might be more likely to have complete absence or reduced number of drinking days. There was no improvement in the number of patients that maintained complete abstinence from alcohol with antabuse compared to placebo, and there was a reduction in number of drinking days on antabuse. So it may be that antabuse is more effective in certain populations, being highly motivated patients. There actually was an old physician study of physicians with alcohol dependency, and they found that that particular group did well on antabuse. But honestly, in a higher motivated population, they almost do better no matter what kind of treatment they're receiving. There might be a role of antabuse in mandated or supervised administration situations. So perhaps in the military where they're mandated to take it, perhaps in probation, maybe it would make a difference in those kind of settings. So that's all I'm going to say about antabuse. So you can see the results were not that impressive. This is why this is not a medication that I use very often. In fact, a few times I have used it, it was the patient requesting it, and I agreed to do it as long as I could put them on something that I knew was more effective, which was some form of naltrexone. So we're going to talk about oral naltrexone. It used to go by the name Revia. So Revia, or oral naltrexone, received FDA approval for alcohol dependency in 1995. It's an oral medication. It's taken once a day. It's a 50 milligram pill. Now, a lot of times, if I'm going to use oral naltrexone, I may start out by having them break the tablet in half and do half a tablet a day for a few days before going up to 50 milligrams. I find that reduces the nausea that they may initially experience. Naltrexone is an opioid receptor antagonist, hence cannot be used in anybody who's receiving chronic opioids for, say, pain management, or anybody who's on buprenorphine maintenance. Because if they are on, say, buprenorphine maintenance for an opiate use disorder, and you start oral naltrexone for an alcohol use disorder, you will precipitate opioid withdrawal. So why would an opioid antagonist or blocker work for alcohol dependency? Because alcohol does not bind to opioid receptors. Alcohol binds to GABA receptors. Alcohol is kind of a dirty drug. It actually affects a lot of different receptors, but primarily it binds to GABA receptors, which is the same receptors that benzodiazepines and barbiturates bind to, which is why we can use benzodiazepines or barbiturates to detox somebody from alcohol. So why would an opioid antagonist work for alcohol dependency? Well, a few decades ago, there was an old theory called the THIQ theory. So tetrahydroisoquinone. So a researcher found this substance, THIQ, in the brain of patients who had died of chronic alcohol dependency. And the theory was that when the person has chronic alcohol dependency and they drink ethyl alcohol, we know it breaks down to acetaldehyde, and that acetaldehyde binds with various neurotransmitters to form this substance called tetrahydroisoquinoline, which is an opioid and binds to and activates the opioid receptor. However, this theory has been pretty much debunked because nobody else has been able to reproduce the data. Nobody else has been able to find this substance, THIQ, in the brains of chronic alcoholics. So since then, it's been debunked. I bring it up more for historical interest. So back to the question, how is it that an opioid antagonist helps with alcohol dependency? So the ingestion of alcohol causes release of our natural occurring endorphins within the brain. And that appears to be genetically controlled. So the non-dependent person, when they have a drink of alcohol, they may get a small release of endorphins. The person who has alcohol dependency or is genetically at risk for alcohol dependency, when they drink, they get a very large surge of endorphins. And we know endorphins is our natural opioid. It activates our mu-opioid receptor. So consumption of alcohol, endorphin surge. Also, the ingestion of alcohol may somehow sensitize those opioid receptors as well. So a combination of exaggerated endorphin release, hypersensitivity of those mu-opioid receptors, probably both play a role in the euphoria from alcohol use in somebody with alcohol dependency. Naltrexone, being an opioid antagonist, will block that mu-opioid receptor. So when that endorphin surge occurs, it blocks some of the rewarding effects of alcohol consumption. When combined with drug and alcohol counseling, oral naltrexone has been shown to decrease cravings for alcohol, decrease relapses on alcohol, decrease the amount of drinking if there is a relapse, and decrease the number of days of drinking if there's a relapse. So somebody relapses, and instead of drinking then for the next 3 weeks, they may drink for a day and stop. You may have heard of the Sinclair method, and I'm not a big proponent of the Sinclair method. So what is it? So it's a form of harm reduction for those patients who are not committed to abstinence-based treatment. So it's a way for them to continue their alcohol use. You're sort of meeting them where they're at, but trying to do some harm reduction. So the way it works is when a patient wants to drink, they take an oral naltrexone tablet to reduce the rewarding effects of alcohol. And the theory is with time, then alcohol, it blocks the euphoria of alcohol. And with time, they sort of unlearn the behavior of drinking because it just isn't rewarding anymore. And there actually is some evidence that the Sinclair method may be a helpful technique in the short run. In the long run, probably not. And we are trying to find long-term outcomes, but it may be a way to meet the patient where they're at that particular time. So they're going to go to some social event. Hey, I want to have a couple drinks. I'll take my oral naltrexone. So I limit myself to just a couple drinks because it just doesn't reward me like it used to. So we don't want to give the patient the impression that naltrexone is somehow going to make them a normal drinker. So what are some of the potential side effects or problems with oral naltrexone? Well, it shouldn't be started when the person is currently drinking. Now, it's not that something bad will particularly happen, but they are more likely to get some side effects, such as nausea, if they're actively drinking when they started. And you always have the informed consent issue as well. Naltrexone may cause dysphoria in some people. There is a correlation between oral and injectable naltrexone and depression. The two most common side effects of oral naltrexone: nausea, less than 10%. And that's why I usually start with half a pill, and headaches, which is about 7%. Naltrexone is metabolized in the liver. So you have to use it cautiously in those with liver disease or elevated liver function tests. Now, a lot of times I'll have patients that their liver function tests are slightly elevated, but they're less than 3 or 4 times elevated. And you start the oral naltrexone and monitor their liver function test closely. And inevitably, what you tend to see is a decrease in their liver function tests because their drinking diminishes or stops. And it was the drinking that caused the elevated liver function test. And as I already mentioned, oral naltrexone will precipitate opioid withdrawal in the opioid dependent population. So if they're a chronic pain patient on chronic opioids, if they're on Suboxone maintenance. The FDA recommended when naltrexone come out a duration of treatment for 3 months, which doesn't make real good sense to me because the vast majority of relapses with any addiction, not just alcohol, occur in the first 3 to 4 months. So those in the field generally treat patients for a lot longer than 3 months with oral naltrexone. And as I already mentioned, although it has naltrexone has a possibility of causing rise in liver function tests, and generally you see a drop in the liver function test because drinking stops or decreases. There does appear to be some populations of alcohol-dependent individuals that may benefit more than others from oral naltrexone therapy. Those patients who have a much more progressed form of alcohol dependency do not seem to benefit as much from the medication. Almost like the further down the path they've gone, the less benefit they'll receive from oral naltrexone. Kind of true for a lot of diseases. The further progressed the disease is, the less responsive the disease is. And it may be because if they've further progressed with their disease, maybe they've lost a lot of the psychosocial support that might have been helpful in maintaining and achieving abstinence. Years ago, we sort of group the alcohol dependent population into 2 types, the type 1, which I call your run-of-the-mill alcohol dependent patient, and the type 2, and which we'll talk about in a second. The type 2 alcohol dependent patient seems to benefit much more from naltrexone therapy. So what is the old term type 2 alcohol dependent person? So generally it's a young male. They have a very rapid progressive disease. They tend to have very high risk-taking behaviors, and typically they have a father with alcoholism. So there's a very high genetic load in this type 2 alcohol-dependent population. Those with a very strong family history, a high genetic load, seem to do better with naltrexone as well. And there's currently a lot of research going on looking at various genetic markers to predict who might do better with naltrexone and who may not. There are some controversial uses of oral naltrexone. So since naltrexone has been shown to reduce the severity of relapse, meaning the number of drinks they have if they relapse, it could be used prophylactically in high-risk situations. So somebody might say, well, I'm going to a party. I don't want to drink. I'm going to take oral naltrexone to maybe reduce my cravings to drink. But if I do end up drinking, the drinking may not be as bad. Now, if they go to the party with the intent to drink and take oral naltrexone, now you're looking at the Sinclair method I just talked about. So example, take 1 pill a few hours before going to a drinking event in case a slip or relapse occurs. But again, I mentioned this, we want to be very cautious not to give the message that this medication will make you a normal or a controlled drinker, because for the person with alcohol dependency, those days are gone. One of the characteristics of alcohol dependency is loss of control of their drinking. So let's move on to the next medication, which is Vivitrol. So Vivitrol is an extended release injectable form of naltrexone. So Vivitrol received FDA approval in 2006. It's given as an intramuscular injection every 28 days. It's the same dose for everybody, 380 milligrams. patients should not be actively drinking when starting Vivitrol. Why? Well, one thing is the informed consent. How do you get informed consent from somebody who's intoxicated? Also, if they have some abstinence, or less likely to have side effects. But also, some of the outcome data shows that you tend to get better results if you have some lead-in abstinence. And the studies show that anywhere between 4 to 7 days of lead-in abstinence give you a better result than less than that length of time. But I usually say, I'll take what I can get. If I have somebody coming to me and they haven't drank in 2 days and they want to get on Vivitrol and there's no contraindication to start it, I'm probably going to start it at that time. That's probably a better option than sending them out the door and say, well, come on back in 4 more days. Don't drink for the next 4 more days. And then I'll give you the first Vivitrol injection. When we're treating addiction, we have a narrow opportunity to get them engaged in treatment. And if we don't act during that narrow window, we may lose the patient. So when combined with drug and alcohol counseling, Vivitrol was superior to placebo in treating those with alcohol dependency. It is believed that a once-a-month injection will improve medication compliance compared to daily administration of oral naltrexone. I would say it's more than believed. It's actually been shown now. There was a veteran study that it was a retrospective chart review of patients who were prescribed any medication for an alcohol use disorder. So they looked at patients who received Vivitrol, oral naltrexone, Acamprosate, and Disulfiram, and they looked at how often they filled their prescriptions or how often they got their Vivitrol injection. And what they showed was that the compliance with Vivitrol was better than all of the other 3 oral medications. So I don't want to say I believe that compliance is better. It's really been shown that compliance is better with a once-a-month injection. So the pivotal study that got Vivitrol FDA approval for the treatment of alcohol dependency was published in JAMA in 2005. It was a decent study. It was a 24-week or 6-month study. It was an outpatient, multi-center, randomized, placebo-controlled trial. So patients either received a Vivitrol injection every month and every other week counseling, or they received a placebo injection every month and every other week counseling. Patients didn't know what they were getting. Again, it was blinded. And there were 250 patients enrolled in this study. So this outcome looks at the median drinking days per month, so number of days they drank per month. So coming into this study, the number of drinking days per month were 16. So that means pretty much every other day they were drinking something. They come into the study. If they get the placebo and counseling, they drop down to 7.2 drinking days per month. So it's like, well, why such a significant drop from 16 days to 7 days when they're just getting a placebo injection? Well, they're getting counseling. So the counseling itself is starting to have an impact on their drinking. And if they receive counseling with placebo, they drop down to less than 1 day of drinking per month. So that's a 90% reduction. And that's what we attribute to the Vivitrol. Now, this is any drinking days. If you look at heavy drinking days, they were at 15 heavy drinking days per month. So whether you're looking at any drinking days or heavy drinking days, there still was a very significant decrease in the Vivitrol group. In the study, they looked at complete abstinence rates from alcohol during the 6 months of the study. So if they received the Vivitrol, there was 32% had complete abstinence rates. So you can see with time, like there were more and more relapses, but about a third went the entire 6 months without any alcohol use versus placebo, which about 11% went the entire 6 months without alcohol use. So, so almost tripling complete abstinence rates with Vivitrol counseling. Once this looks at serum naltrexone levels with both oral administration versus a Vivitrol injection. So with oral administration, they take the pill, their level comes up, comes down the next day. They take the next pill, levels up, comes down the next day. With the Vivitrol, they get their injection. They get a little spike in their naltrexone levels a few hours later, and then a larger spike at days 2, 3, 4. And then it comes down and reaches a near steady state level out till day 28 when it's time for their next injection. So does a more steady state blood level have any, from an injection, does that have any clinical significance? Meaning, is that more sustained level better than daily administration with up and down levels? And the answer is we don't really know. Is medication compliance higher with injectable naltrexone? Yes, I told you that VA study did confirm that. Since both medications, oral naltrexone and Vivitrol, when combined with drug and alcohol counseling, have been shown to be superior to placebo, a head-to-head study of oral naltrexone and Vivitrol would need to be done to see if one is superior to the other. I don't think we're going to see that study. I've scoured the internet many times trying to find somebody who's done that study, and I can't. The best that I could find was oral naltrexone versus Vivitrol, looking at the length of time to first relapse. So with oral naltrexone, the length of time to first relapse averaged 50 days. With Vivitrol, it averaged 150 days to first relapse. So it kind of tripled the period of sobriety before the first relapse. And this is kind of the best that I've been able to find in terms of head-to-head of the two medications. What are some of the disadvantages of Vivitrol? Well, it does require a monthly doctor visit for the injection. I don't know that that's a big disadvantage. I think anybody in treatment for a substance use disorder should have regular interaction with their physician. There may be pain at the injection site. You can get some injection site reactions. It can't be used in chronic pain patients or patients on buprenorphine maintenance because it will precipitate opioid withdrawal. And the cost of the medication, it's close to $2,000. Probably the majority of my patients have medical assistance, and medical assistance is super easy to use for Vivitrol. I can just call up my specialty pharmacy and have it delivered within 24 hours at no cost to the patient. Some of the commercial plans are a little more difficult. Sometimes they require prior authorizations. Sometimes it's run under the prescription part of their policy. Sometimes it's the medical part of their insurance, and that generally takes some investigation. There may be copay issues. There may be deductibles that they have to reach. But if you're paying out of pocket, it's extremely expensive. So this leads us on to our third medication, Acamprosate or Camprol. So this medication received FDA approval for alcohol dependency in 2004. However, it's been used over in Europe for over 20 years. It's a weird strength. It's 333 milligrams. And the way you take it, it's 2 pills, which is 666 milligrams, 2 pills 3 times a day. We know that compliance goes down when medication frequency goes up. So sometimes I have trouble remembering to take my morning Prilosec. Here, with this medication, you have to take 2 pills 3 times a day. You could imagine compliance may not be that great. Most common side effect is diarrhea. A little over 20% have it. Anxiety or depression, headaches, and sleep problems. So how does Acamprosate work? So here is a cluster of neurons in our brain. So we have our cell body, our axon, comes down to the synaptic cleft here. So when this neuron wants to send a message, an electrical signal comes down the axon. When it gets here, a neurotransmitter is released and binds to a receptor in the dendrite of the following neuron. So kind of blowing up that synaptic cleft. The electrical signal comes, these neurotransmitters then migrate out and are released right there in the gap. Some are reuptaked and some pass on and bind to the receptors. And there are multiple neurotransmitters, dopamine, we talked about endorphins, serotonin, norepinephrine. We have an inhibitory neurotransmitter called GABA, gamma aminobutyric acid. And we also have its complement, which is an excitatory neurotransmitter, which is glutamate or glutamic acid. So normally these two are in balance. So in the average person, your GABA levels, your glutamate levels are in balance. So we're not overstimulated, we're not over sedated. It's believed that with the chronic use of alcohol, this results in a imbalance in these neurotransmitters. So if our GABA level is here and our glutamate level is here, and then chronic alcohol use begins, well, the alcohol is binding to the GABA receptor. So you don't need to make as much GABA. So GABA levels then begin to drop. Then when they stop drinking, you have low GABA levels, which is our inhibitory neurotransmitter, and high glutamate levels, which is our excitatory. So it's believed that that imbalance then results in much of the anxiety, restlessness, and cravings for alcohol that somebody goes through in their early recovery process. So it's theorized that what acamprosate does is more quickly restore the balance between those two medications, reducing the cravings for alcohol, therefore reducing relapses. And acamprosate has been shown to improve absence rates and reduce drinking days. So what's the best treatment for alcohol dependency? We have these 4 medications. So should we be using medication and medical management, meaning interaction with a physician or a physician extender? Or should we do drug and alcohol counseling? How about counseling with medications? What medications? What about the combination of medications? So a lot of questions that then come up. So in an attempt to answer some of these questions, a fairly large study was done called the Combine study. So it's a randomized controlled trial that went from January of 2001 to January 2004 and involved 1,383 patients who met the DSM-4 criteria of alcohol dependency. And there were 9 different treatment arms in this study. And they were these treatment modalities went on for 16 weeks. And although treatment only lasted 16 weeks, the patients were actually followed for a year. So these are the 9 different treatment arms in this study. So the first group, medical management, which means they saw a physician or healthcare extender regularly, and they were given oral naltrexone, and half received cognitive behavioral therapy counseling and the other half didn't. We had those who had medical management and received oral acamprosate. Half of them received counseling, half of them didn't. We had medical management plus oral naltrexone plus acamprosate, 2 medications with and without counseling. Medication management with just placebo, with and without counseling, and then counseling alone without any physician interaction, without any medication. And the main outcome they were looking at in the study was percent of days abstinence. So the study showed there actually were 3 groups that did well, or the best 3 groups were those who had medical management, so regular contact with healthcare provider, received oral naltrexone, so 88.6 days of abstinence. Another group that did well, those who had medical management, got a placebo, but got counseling, 79.2 days of abstinence. And those who had medical management received oral naltrexone and counseling, 77 days of abstinence. Now, when you first look at that, you might think, well, wait a minute. Those who saw a physician got oral naltrexone did better than those who saw a physician got oral naltrexone got counseling. So was the counseling somehow like even hurting them, so their outcome was worse? No, because of these 3 groups, there was no statistical significant difference. So all we can say is these 3 groups did equally as well. But as you look at these 3 groups, 3 of them, all 3 had regular contact with a healthcare provider. 2 of the 3 got oral naltrexone and 2 of the 3 got counseling. The combined study also showed that counseling alone without any medications involved did not do as well. In this study, Acamprosate did no better than placebo. And let me kind of regress to Acamprosate. There's been a lot of studies looking at Acamprosate, and it's been mixed reviews. Some studies say it's beneficial, some that shows no improvement over placebo. But when you have a lot of studies, you do meta-analysis, and when you do meta-analysis, there did seem to be better outcomes with Acamprosate over placebo. But in this one study, Acamprosate did no better than placebo, and adding Acamprosate to oral naltrexone did no better than oral naltrexone alone. So what did we learn from this study? This is the first time that's been shown that a medication, which was oral naltrexone, can improve outcomes of patients with alcohol dependency without any drug and alcohol counseling. So hear that loud and clear for the primary care physicians. Like, we can make a difference just as a physician and prescribing oral naltrexone. The study does suggest that if the patient's receiving drug and alcohol counseling, they should have open lines of communication with a primary care physician, because it appears that involvement in that physician improves the outcome. What's the role of the primary care physician? So many primary care physicians are not knowledgeable about oral naltrexone and therefore may be reluctant to place their patients on it. Hopefully, we're sort of breaking some of that barrier today. And the primary care physician should feel comfortable screening patients with alcohol dependency and using pharmacotherapy when it is appropriate. So we're going to move on to some off-label medications for alcohol use disorder. Topiramate, Baclofen, Gabapentin, Ondansetron, or Zofran. So Topiramate, so it's approved for the treatment of seizure disorders and prophylaxis for migraines. It is used as a mood stabilizer in patients with bipolar disorder, but that's not an FDA-approved indication. That would be off-label. It's not currently FDA-approved for the treatment of alcohol dependency, so if you're using it, it's off-label. There is some preliminary data that suggests it may be beneficial in the treatment of alcohol dependency. So we'll review one of the studies. So this was JAMA 2007. So it was a 14-week study that followed 371 individuals with alcohol dependency. The patients were given up to 300 milligrams of Topiramate or placebo daily, and they had weekly nurse appointments to monitor compliance. They received no drug and alcohol counseling in this study. The outcome they were looking at was percent of heavy drinking days. What's a heavy drinking day? 5 or more drinks for a male, 4 or more drinks for a female. So what they found at baseline coming into the study, both the placebo group and the Topiramate group before they started the study, percent of heavy drinking days was 82%. So 82% of the days was a heavy drinking day. So there's a lot of alcohol use going on. If they then come into the study and they get placed on placebo, they drop down to 52% heavy drinking days versus Topiramate, 44% heavy drinking days. So placebo versus Topiramate, not a huge impact, not a huge difference, but statistically significant. And that's kind of all I'm going to say about Topiramate, again, off-label use. What about Baclofen? So it's not an FDA-approved medication for alcohol dependency. Baclofen's an antispasmodic medication. The mechanism of action of Baclofen, it binds to GABA B receptors. So it's a GABA B receptor agonist, and stimulation of the GABA B receptor may reduce cravings or anxiety and reduce the rewarding effects of alcohol. So there have been several small studies that have been done looking at Baclofen for the treatment of alcohol dependency. These studies range from 12 to 39 participants. So these are very small studies. Some of the studies were open label. Patients knew exactly what they were getting. The dose range typically went to 10 milligrams 3 times a day. So very small studies. This is not going to show to prove to be the silver bullet treating alcohol dependency. But what did they find in these studies? So with Baclofen, there was a reduction in the number of heavy drinking days, increase in abstinence rates, reduction in the average number of drinks per day, reduction in alcohol cravings, reduction in anxiety. So all those sound good. Those are good outcomes that we're looking at. But again, very small studies, not definitive. And then gabapentin for the treatment of alcohol dependency. Little stronger evidence here. So a 12-week double-blind placebo-controlled trial with randomized dosing of gabapentin from 900 milligrams 900 milligrams a day to 1800 milligrams a day. This study had 150 participants, so moderate-sized study, double-blind placebo. What they found was with the use of gabapentin, abstinence rates were only 4.1% in the placebo group versus 11.1% in the gabapentin group. So statistically significant difference in complete abstinence rates. And when they looked at a second outcome, no heavy drinking rates. So no heavy drinking rates, 22% in the placebo group, 29% in the gabapentin group. So yes, that was statistically significant. So I think there's a little bit more stronger data for gabapentin than there is for Topiramate, and certainly than there is for Baclofen. And then Ondansetron, so this Zofran, you may know it by, so it's an antiemetic medication that is an antagonist at the 5-HT3 receptor, so one of the serotonin type receptors. There have been several small studies that have been done to look at Ondansetron on various drinking outcomes in those with alcohol use disorder. The doses in these various studies range from 4 milligrams a day to 16 milligrams a day. Some of the studies show a small but statistically significant improvement in drinking outcomes. I'm not going to go through all the small studies that were done. But something interesting is starting to evolve with Ondansetron. So we're going to talk just a little bit about genetics. It certainly gets way out of my area of expertise. So some individuals with an alcohol use disorder have a genetic variation known as the LL plus TT polymorphism. This results, if you have this polymorphism, this results in the expression of more postsynaptic receptors, the 5-HT3 receptors. So by using Ondansetron to block these serotonin receptors, serotonin function is stabilized, and as a result, alcohol cravings are reduced. So in other words, we may in the future be able to genetically target certain patients who have this polymorphism and say, these are the patients that are going to do better with Zofran than the general population of those with alcohol use disorder. I want to throw one other thing in. Was it last week? 2 weeks ago, somebody in the audience asked about using the GLP-1 medication. So that would be like the Ozempic type medications, that there was some data that it might be helpful in certain substance use disorders. So I did sort of scour the internet a couple weeks ago, looking for what I could find specifically for the GLP-1 medications for alcohol dependency. And there are several rodent studies that showed that these medications are changing drinking behaviors in rodents. And there's some anecdotal evidence of 6 patients that were in a weight loss clinic, received a GLP-1 medication, and reported that they had a reduction in their drinking. So it's more anecdotal evidence. So I don't think that we have strong enough evidence to say we're going to use these medications to treat an alcohol use disorder. Okay, so in summary, so alcohol use, alcohol-related deaths, alcohol-related emergency room visits have all been on the rise, particularly since 2019, when the pandemic hit. Medication-assisted treatment for alcohol use disorder is underutilized. Remember, it was like 1.6% of patients with an alcohol use disorder ever got prescribed any medication-assisted treatment. First-line therapy would probably be oral or injectable naltrexone. But again, you have to be cautious if they have abnormal liver function tests. That pilot study that I looked at for Vivitrol, so there were two pilot studies for Vivitrol, one for alcohol use disorder, one for opiate use disorder. And one of the studies, I can't remember which one was which, one allowed liver function tests as high as 5 times normal to enter the study, the other up to 3 times normal to enter the study. So in general, I will go up to 5 times normal liver function tests before I decide I'm not going to use Vivitrol or oral naltrexone. So first-line therapy, one of the naltrexone preparations. Acamprosate is an alternative if the patient is on opioids or has severe liver disease, but you have to be careful with acamprosate in the setting of severe renal disease. So I do have a couple patients right now on buprenorphine maintenance for their opiate use disorder, and they're really struggling with their drinking. Naltrexone is not going to be an option for them, so acamprosate may be. Second-line therapy might include disulfiram antabuse, particularly in the setting of witnessed administration. Topiramate or Gabapentin, I would more likely lean towards Gabapentin just because there seems to be a little stronger evidence there. And then there is evolving data on using Ondansetron as genetically targeted therapy, those who have that polymorphism. And this is the picture of my family. We are about 17,000 feet up in the Andes Mountains in Peru at a place called Rainbow Mountain. And you can see why it's called Rainbow Mountain. And picture doesn't show it, but I'll tell you all our lips were blue at that altitude. So with that, I will conclude.
Well, we have one question in the chat, Dr. Davis. Dr. Murdoch would like to know, how about using Vivitrol and pre-high-risk exposure naltrexone PRN?
So I don't use Vivitrol as a prophylactic medication or for those at risk. If they commit to Vivitrol therapy, they get a monthly injection, and I typically run it out to about a year, sometimes longer. If they want to do the Sinclair method and use oral naltrexone prophylactically, yes, I'll do that. But try to work them towards a goal of complete abstinence. If they, I don't necessarily give oral naltrexone prior to initiating Vivitrol. So if they're coming to me as a new patient and they are willing to go on Vivitrol, I typically will not give them oral naltrexone first. I just go ahead and give them the Vivitrol shot. And here's the reason I do that. Oral naltrexone can be pretty nauseating. And if I give them an oral naltrexone and they get nauseated, they'll refuse the Vivitrol shot. But the Vivitrol shot tends to cause less nausea. So I don't want to burn that bridge of being able to give them the Vivitrol injection. I've had patients who wanted oral naltrexone therapy first, and sometimes they did well, but if they continue to have relapses, I'll move them right over to Vivitrol if they're willing to do that. And I have, in a few cases, seen improvements where they've achieved complete abstinence once I moved them over to Vivitrol. So I guess the answer to the question is I don't use Vivitrol prophylactically. I use it as maintenance therapy. Some patients want to use oral naltrexone prophylactically.
What would be your starting dose for Topamax should you choose to use that?
50 milligrams.
Once a day?
Yeah.
And
then
move titrating that up?
Right. And I've only ever used it a few times. It was in a patient that also had bipolar disorder, and I thought there could be an added benefit. Weight loss tends to be a big problem, and this particular female that I put on it was very thin, and we had to monitor her weight closely to make sure she wasn't losing.
Dr. Murdoch's comment was just naltrexone. Naltrexone will be add-on Sinclair method with maintenance Vivitrol. I don't know if that's a question or a comment.
Read that again, Rachel.
Naltrexone would be add-on Sinclair method with maintenance Vivitrol. Dr. Murdoch, do you want to unmute yourself and talk? If he's still here.
Well, let me say this, because if they're on maintenance with Vivitrol, I don't usually have them take oral naltrexone in addition for the high-risk situations. But what I will do is I will give them a prescription of oral naltrexone for a handful of pills, so that if they miss their next injection and they can't get in for another week, I will tell them, go ahead and take the oral naltrexone until you can come in. So kind of as bridge therapy until they get their next injection. The other thing is, when you give them that first injection, they tend to, before it's time for their next injection, they do tend to have heightening in their cravings. Now, after they've gotten injection 2 or injection number 3, you don't see it as much. So I tell them, if in the last 4 days of the month, before your next Vivitrol injection, if you're really struggling, go ahead and supplement with oral naltrexone for those couple days until you get your next injection. So,
and that was my question. That's what my thought was based on the pharmacokinetics of the Vivitrol. But once you reach steady state, it's probably pretty close to what daily naltrexone would give you if you took it orally. Is that correct?
yes.
Okay,
So,
thanks.
yes, exactly. But it seems to take a couple injections of Vivitrol to really get their cravings down. So I will bridge with or supplement just to buy a couple days if they're struggling. Okay.
Are there any other questions?
I don't see.
I'm sorry, Janet?
I don't see any more. I think we're good.
Okay. Well, Dr. Davis, I would like to thank you for this wonderful presentation and all of you for joining us. We look forward to seeing you again on the 20th for the CCMS lecture on stigma. Thank you all and have a wonderful evening.
Thank you.
Great lecture. Thank you.
Thanks much.